So welcome to this evening's lecture. For those of you from outside who don't know me, I'm Mark Hummer, Deputy Vice-Chancellor and Provost. It's a great pleasure to welcome you to this lecture, which is hosted jointly by the School of Law and the Institute of Liberal Arts and Sciences. This lecture actually marks the start, or is a lecture in the School of Law's 50th anniversary public lecture series, and also is the first lecture in our 2017-18 Grand Challenge lecture series organised by the Institute of Liberal Arts and Sciences. When you look back, there's always statistics that kind of really make you smile, but when the School of Law was first started in 1965, and you could come to Keele to study law for the first time, you'd have been one of 7 students taught by 3 lecturers, and it kind of partly shows how Keele's grown, but also how participation in university has really grown as well. So School of Law now a flourishing school with over 750 undergraduate, postgraduate students, academic and professional services staff, and 50 years on, working towards golden anniversary of the first graduating law students. I assume that all 7 students that started did graduate, and so there's 100% completion. And we have a lecture to commemorate the anniversary around other achievements, celebrating the achievements of Keele Law alumni, which there have been many, and also an opportunity to showcase the life and ethos of the school through its current research and teaching and its plans for the future. So future speakers in the series include Professor Sally Sheldon, 50 years of the Abortion Act since 1967, Sir Maurice Kay, judicialising government and politicising the judiciary, Sir Ernest Ryder, assisting access to justice, and Michael Mansfield QC, 50 years on. I'm glad I studied philosophy at Keele. Celebrations will then conclude with a summer event that will mark the 50 years since graduation of those first Keele Law students. I'll just say a few words about the Grand Challenges lecture series. So, as mentioned, this is a partnership event between School of Law and ILAS, and it's the first in this year's Grand Challenge lecture series. And the point of these lectures is to offer interdisciplinary perspectives from eminent scholars on the complex societal and intellectual problems we face today, and problems which require bringing together of different knowledges and different skills and expertise to produce creative, fresh thinking on, say, complex societal problems or societal grand challenges. And our speaker this evening is someone who has a huge amount of experience of working across fields and of breaking down barriers to find common fresh ground. So Professor David Croisdale-Appleby is both a career and an academic polymath. He's got interests that span medicine, health, social science and science, so across all 3 of our faculties at Keele. Holds many important ministerial appointments in health and education and professorships in a variety of disciplines. He's chair of the Science Council and Dementia UK, Health Education England. He holds responsibility for higher education, medical education, quality and the NHS Leadership Academy. He's the author of the independent review of social work education, Revisioning Social Work Education, which was published by the government in 2014, which forms the basis for the current reforms in social work education and training, which Keele University contributed to. And his work is focused on improving the lives of vulnerable and disadvantaged people, something very important to work we continue to develop at Keele. And he's chaired many organisations representing and promoting their interests. So in tonight's lecture, Professor Croisdale-Appleby traces the development of integrating health and social care in England over the past 20 years, from Torbay to the current Vanguards and STPs. And he contrasts this with international examples, and he explores the challenges that integration brings, including leadership, and examines the need for new roles which will extend the capacity of health and care professionals to deliver future services that must be developed to serve emerging and future needs. So that was quite a long introduction, and I've barely done justice to David's achievements, but it's a great pleasure to introduce Professor David Croisdale-Appleby to give his lecture, Integration, and transforming the health and social care workforce, or hunting the Snark. So, David.
Well, of course, it's a rather strange week to be giving a public lecture, having just come back from Manchester, where there are a number of public lectures that you'll be well aware of. So, as I stand here, I just have to be slightly careful. Normally I would clear my throat at the beginning, but I'm hesitant about doing that. I have 2 glasses of water here, just in case. I also was concerned because behind me I have School of Law, and I thought, well, if the L falls off, it'll be School of Awe, and, you know, that's it. But my final thing is a request. I quite understand if part of the way through my presentation you feel that giving me my P45 is entirely appropriate. I would just remind you that I'm not actually an employee of this organisation, so it will be a gesture, but it won't have any reality behind it. Well, today I'd like to take you, if I may, on 2 parallel journeys. The first journey is to seek to ensure that the recipient receives integrated care, and the second is Lewis Carroll's mythical journey of 1876, the hunting of the Snark, which I hope will illuminate some points of the first journey. So, why the Snark? Well, according to Skeet's Etymological Dictionary of 1882, I realise that that's a cherished bedside companion of all of us here tonight. The word derives from 2 Aryan roots, drawing disparate things together and binding them tightly as one. So it seemed to me that this was a large part of what we're trying to achieve in the integration of health and social care. But Lewis Carroll's journey to hunt the Snark contains a warning to us on our own journey, which is that the Snark itself had a property which meant once captured it would, to quote, softly and suddenly vanish away, for the Snark was a boojum, you see. So I pose the question, as we pursue and achieve integration, will it turn out to be a goal that we all hunted and pursued, but in the end proved to be an illusion like the Snark? Now, our own journey begins in Torbay. Torbay, population of 140,000, with nearly half as many older people again as the UK average. Meeting the health and social care needs was a local issue that required a local solution, but perhaps not the local shop for local people approach of the League of Gentlemen series. So rather than Tubbs and Edward, the wise burghers of Torbay invented a fictitious but representative Mrs. Smith, a lady in her 80s who required both health care and social care. They knew that as the population aged and more of that aging population chose that delightful part of the country for their retirement, that there would be more and more Mrs. Smiths. So the Torbay story began with the creation of an integrated health and social care team in Brixham, which is part of Torbay, in 2004, which worked with GP surgeries to help those older people who are most at risk, focusing on enabling them to remain living independently for as long as possible. Well, it worked. Discussions began to bring together the functions of the Primary Care Trust, the adult social care services provided by Torbay Council, coordinating GP surgeries, the acute hospital, and the local authority. But this was fraught with difficulties, particularly around staff and, of course, whose budget paid for what. This led to the suggestion of a care trust, which was strongly supported by the local authority. and indeed by the newly appointed Health Secretary, Patricia Hewitt, and she gave approval for the creation of the Torbay NHS Care Trust in 2005. So that happened well over a decade ago, but the move from that team in Brixham to the new Care Trust only took about a year, proving that we can move fast when we want to, when ideas make sense, and when evidence proves what works. Now, I take 3 key lessons from Torbay's stories, lessons for today. The naysayers, with a mixture of gloom and relish, as all naysayers have, state as axiomatic that it takes a long time to change public services, and Torbay proved that it doesn't. So consign your gloom merchants to the bin. Determination, focus, and the collection and use of evidence, which is something done from the very start in Torbay by local leaders, overcomes obstacles and makes change happen. Now, I mention focus because at Torbay they had, and indeed they still have, a very simple test. Does this proposed activity improve people's health and well-being outcomes? Focusing on this keeps at bay the demons of unnecessary complication, but much, much more importantly, it defines integration as what is experienced by the user and not using the surrogate of a coordinated delivery system. Change is sustainable where it brings together people from their different perspectives and agendas to design the integrated activity and not imposing the leadership of any one faction. The most significant aspect of the Torbay story is how the local authority worked together with the local NHS organisations and many others to change the whole system of care to improve outcomes. And they built a bridge across rather than dismantle the wall between in order to overcome the traditional chasm between them, something that took vision and leadership. And I don't think that Donald Trump's wall-building approach to Mexico would have appealed to the visionaries of Torbay. Now, work on integration in Torbay continues as an integrated care pioneer, one of the 5-year forward views Vanguards, of which there are 50, acting as blueprints for the NHS in the future and the inspiration to the rest of the health and care system to work together. This vision includes support for individuals, carers and communities, a much greater emphasis on prevention and new models of care at a local level. Now, those 50 vanguards are classified into 5 types. Firstly, integrated primary and acute care systems. That's joining up GP, hospital, community and mental health services. And second, multi-specialty community providers, moving specialist care out of hospitals and into the community. The third one is enhanced health in care homes, offering older people better joined-up care and rehabilitation services too. And there are many examples of those that I'll mention some tonight. The fourth, urgent and emergency care, with new approaches to improve the coordination of services and reduce pressures on A&E departments. And finally, acute care collaborations, joining up acute hospitals and clinical networks, such as those that you'll be familiar with, for such as cancer care. The intention is to redesign the whole health and care system, and thereby people with cancer needing fewer trips to hospitals, dementia specialists holding clinics in local surgeries, having a single point of call for family doctors, community nurses, social and mental health services, and access to blood tests, dialysis and chemotherapy closer to home, some of those in the home. They're also joining up the often confusing array of A&E, GP out of hours, minor injuries clinics, ambulance services, 111, so that patients know where they can get urgent help easily and effectively 7 days a week. But one has to travel a long way from Keele to find a Vanguard project. And perhaps the closest Vanguard project is the National Orthopaedic Alliance of 5 acute hospitals, including, you'll be familiar with the Robert Jones and Agnes Hunt Orthopaedic Hospital near Oswestry. Of its 4 objectives, undoubtedly the first 3 are worthy to any form of collaboration, and rather than take you through them, I'll sum them up as do orthopaedics better clinically, increase patient satisfaction, and in the process reduce costs. So that's fine, that's the first 3 put. But it's the 4th objective, which is the transfer of knowledge to the wider than just orthopaedic service, that I would look to for lessons. But of course, this is integration of different providers of similar services. It's not the integration of health and social care that I referred to before. Now, my eyesight is such I have to keep checking which ones I'm with. A Vanguard in a different geography that does seek for such integration of health and social care that I've used because I just think it's helpful, it's not quite in our area, I appreciate, is Calderdale Health and Social Care Economy. And that's a multi-specialty health and social care economy vanguard, one of the 5 categories I mentioned earlier. This delivers care that is personalised and helps individuals to manage their own health and well-being. Its delivery is supported through increased volunteering and social action. The Vanguard is made up of many partners, including a federation of 26 GP practices, 2 hospitals, the local authority, there's only one, the CCG, Clinical Commission Group, and Voluntary Action Calderdale, which represents over 100 third sector organisations that are working in healthcare related sectors. The Vanguard already has delivered improved access to health and care services through a reshaped first point of contact, where care coordinators are supported by community-based volunteers and professionals from a range of disciplines. It's already provided enhanced levels of care to people with complex needs. More care is being delivered in the community and primary care settings, and this has led already to many fewer hospital admissions. So fundamentally what it does is to place people at the centre of their own care, empowering them to access the right care at the right time and in the right place. However, it must be said that such examples as I've given you take no account of the Hawthorne effect, whereby human subjects of an experiment change their behaviour simply because they're being studied. Since the Vanguard initiative was instigated, the NHS England 5-year forward view, which aims to make £22 billion of efficiency savings by 2021, has focused on 44 sustainability and transformation plans, STPs, that are aimed to provide joined-up health and social care provision in very local health economies. Now, you might ask, how do you define a local economy, local health economy? And it is basically where there just seems to be more association and there seem to be boundaries. So it's not all that scientific, but it's an attempt to break the national picture down in a sensible way. And hopefully eliminating inefficiencies, wastage, and demonstrating new models of integrated care. But already these have encountered problems. And in November, the King's Fund issued a report based on a very small sample of chief executives of STPs, which suggested that the problems included, and you'll be familiar with these problems, poor involvement of local government, inadequate involvement of clinicians and frontline staff, the voice of patients and the public being largely absent, and lack of an adequate governance structure or clear lines of authority for decision making. Given that it doesn't have these things, I did rather wonder what it did have. However, I would add 4 further thoughts for your consideration. The first is that the focus of the Health and Social Care Act on competition makes it more difficult for organisations to work collaboratively, and this is something that your School of Law, I'm sure, will have looked at. The second point is that the big pharma or the pharmacy sector as a whole is not represented to any significant degree in STP plans, yet it's assumed that its cuts in medicine costs will be a very significant element. So how are we going to achieve that? The third point is how lessons of success in one local health economy are to be promulgated and adopted in other local health economies. You see, there's always a danger if you have models that are based on the medical model. You know, if we devise a new surgical renal intervention in the Freeman Hospital in Newcastle, the chances are you can take it across the country to the southwest to Derriford and it'll work. But that is not the case by any means for anything that moves anywhere near the social care area. And the fourth point is the plans seem blind to the huge impact involving social workers can achieve in increasing the effectiveness and health of social care in the future. I mean, they seem to forget, you know, we have around about 88,000 social workers in this country. It's a very big workforce. They're not well represented in STPs. So let me focus on the last of these, the missing contribution that the nation's 80,000 plus social workers can make to this agenda. As I said, social work's presence in the new models of care is at best only marginal. There are, in my view, 2 main reasons for this. The first is that those in the health system see it as a clinical system, where needs become real when they're clinical needs, and solutions are real when they're clinical solutions. So referring back to Tubbs and Edward in Royston Vasey, local shop for local people transmutes into clinical solutions to clinical problems. But those of us who visit A&E departments know that they are filled with frequent flyers, those people whose symptoms may or often may not include the need for medical or other clinical interventions, but whose underlying issues are social and need resolution through relationship-based approaches, not by ever-repeating ineffective short-term interventions. Now, our health system, and particularly some of the new models of care, are recognising the need for frontline psychiatric interventions and drug and alcohol treatments, but now need to radically up their game to recognise the huge drain on the healthcare system caused by failing to identify and address socially based problems which become emergency health issues if they remain undiagnosed and untreated. So that's the first. The second of my 2 reasons is that social work needs its own professional and educational leaders to up their own game and impact upon decision makers in the health system, requiring them to move well beyond their traditional comfort zone. And in my independent review of social work education that Mark referred to, amongst my 22 recommendations for the future of the profession was recommendation 8, which was that social work, qualifying education, and continued professional development, CPD, should equip social workers to play a much greater role in major transformational developments such as the closer integration of healthcare and social care. And I know from my own personal experience in running hospitals, by bringing social workers into hospitals, delayed discharges, bed blocking, and inappropriate A&E attendances were all reduced very, very significantly. Social workers have always been at the forefront of bringing about change in society, and here is an emerging health and social care problem to which solution they can make a huge difference. So I invite the social work department of the university to look at this. This is a big ticket item. This is a big opportunity, and I would love to see social work at Keele take this on. Now, here at Keele, we're close to 2 STPs, Staffordshire and Shropshire, Telford and Wrekin. So I want to look at more detail at the Staffordshire STP, which stated the following major challenges that it faced in terms of its health and care system. Increasing elderly population, their term explosion, of chronic disease and comorbidities, deprivation, rising levels of obesity and diabetes, and acute providers failing to meet urgent care and cancer targets. Now, surely this presents a necessity, not just an opportunity, for major transformation. But so far, its overall STP progress rating needs most improvement, which is not encouraging. Turning now to our latest integration model, we've had Vanguards, I've talked about STPs, accountable care organisations. Now, this still seems to be a mystery to most people, so I'll try and explain what they are. Accountable care organisations is well established in the United States in provider form, but that is not the form that we're intending for England. We're basing what we're doing on the Alzira model in Valencia in Spain, which began more than 20 years ago. And 2 years ago, the King's Fund carried out an evaluation of the Alzira model and its relevance to the UK, and concluded that it both enhanced outcomes and lowered costs. Now, the first accountable care organisation, ACO, is in Northumberland, and that will come on stream by December of this year. The second ACOs will be in Manchester and Dudley, and they will come on stream in April 2018. And the third tranche will be 9 others, which will come on stream by April 2019. And I'm particularly interested in the ACO model proposed for Dudley, in which local authorities are playing a major social care-led approach, using the ACO as their vehicle for integrating health and social care. So what are they, these ECOs? What do they mean? You know, what's their characteristic? Well, the biggest change is the blurring of the purchaser-provider split. Now, this is a fundamental change in philosophy for our health and care system, and it immediately brings it into conflict with the 2012 Act, brackets, Department of Law, please note and comment on. In essence, this is no less than a move away from market competition to collaboration, where the STP becomes the informed commissioner, assessing and reflecting local needs, what the STP does, and the ACOs become the predetermined providers of the service. Now, in this Parliament, there is simply no time for primary legislation. You know as well as I do why. So lawyers are helping to establish ACOs within the existing legislative framework. And of course, when I listen to lawyers talk about this, although they can do that, they don't half wish that they had a bit of a clean slate to go at, rather than having to fit things, round pegs, square holes, all that sort of argument. But an important legal issue is that the resultant contract allows for variation from the standard NHS contract, whereby the ACO can deliver service directly or through subcontracting. But the simple objective is to define outcomes and to pay for their achievement. Not outputs, not amount of work done, but outcomes, health and well-being outcomes, and pay for those. If it delivers the agreed outcomes and additionally saves costs, then it will receive part of that cost saving. So that's, if you like, the financial incentive for doing it. Now, from a legal viewpoint, its most important innovation is to allow GPs to suspend their existing NHS contracts when engaging with the ACOs, and that removes a major disincentive. You see, if you don't do that, you're asking GPs to move away from their current situation into an employed situation, which may be far less favourable. So that is one major change that ACOs bring about, and I, amongst others, welcome that enormously. But there is an evident conflict of interest between a clinical commissioning group, CCG, and the providing ACO, in which GPs in particular may, of course, be commissioning their own services. As it's proposed that ACO, accountable care organisations' contracts may have a 10-year life, may I humbly suggest to our law school that your legal brains on these issues would be most welcome, and the current plans are out to consultation until the 2nd of November. So, Alison, no hurry, but 2nd of November, it'd be very interesting to see if you can comment on these. Now, the underpinning theme of the Vanguards, the STPs, the new ACOs, is that integration is a no-brainer. It's Hegel's Zeitgeist, the signifier for the future. To be clear, we simply can't continue to deliver and fund health and social care separately. Now, what do I mean by Zeitgeist? Well, to be literal, of course, you, the academics here, and people much cleverer than me, know that it means the spirit of the time, or that set of ideals and beliefs that motivate the actions of members of society at a particular period or point in time. And it contrasts with the great man theory of Thomas Carlyle, which sees progress as the result of the action of heroic personal leadership. Now, this contrast is informative when we look at leadership and ask whether leadership is primarily a quality of an individual and that some people are predisposed to be leaders. We have many leaders, acknowledged leaders in this room. Or whether leadership behaviour is a product of society, as situationists, Zeitgeisters, if there's such a word, propound. Namely, that social influence is what determines human behaviour, including leadership. Now, my reading of the evidence indicates that to develop leadership, you need to acknowledge both constructs play a part. And this subject of leadership matters to you because leadership was key to the success of Torbay and is key to the new models of care. It matters to me because amongst my own personal non-executive responsibility at Health Education England is the £40 million, I think it's 45 million now, £45 million NHS Leadership Academy. So we need to learn all that we can from the Vanguards, the STPs and the accountable care organisations, where we're putting a lot of emphasis on leaders working together across boundaries to inform what we do in future on leadership training at the NHS Leadership Academy, which is where Again, excellent universities, marks such as Keele, can have a major role to play, and we would welcome input. So it's an open invitation from me to you. Contribute to me, suggest things as you can. But what does Lewis Carroll's voyage tell us about leadership? Well, the leader, the captain of the ship, was the bellman, whose leadership quality was visible to his crew in the wisdom that was evident in his face. His key task was navigation. So I've copied his key asset, his navigation chart, which you will see is a perfect blank. In other words, he knew what he wanted to achieve, the Snark, but relied on his only asset, his chart, to help him find it. So not for this leader, the involvement of his crew in leadership, but only in followership, despite the fact that one crew member, the baker, knew a lot about Snarks and their ways. So we move on from leadership to the workforce, which we will need to change in order to deliver integrated care. This will mean working across boundaries with new ways of working and new sorts of staff, as well as an increased focus on primary and community care, something that the medical school at Keele has been right at the forefront of developing, of evidencing, and being successful in implementing. See, Torbay proved that localism and recognising and responding to the needs of local populations, their priorities, their politics, their values, their history, their relationships, will shape the right organisational form. That's why there's not one Vanguard, but 50, not one STP, but 44, and a planned 12 accountable care organisations by April 2019. The new local workforce action boards, charmingly termed LWABs, are workforce forums that the STPs, the 44 STPs and Health Education England are working locally to build. And these will be crucial to meeting the workforce challenges that make future changes sustainable. And there are many challenges in doing this. Some are technical in terms of cross-footprint flows and boundaries, staff working across organisations, and sometimes resolving incentives that pull in distinctly different directions. And some are non-technical challenges, such as building sustainable and mutually beneficial relationships, keeping focus on the longer-term vision whilst delivering in the short term. That's absolutely eternal healthcare challenge. And in balancing the need to move quickly whilst ensuring initial enthusiastic buy-in can be sustained in the longer term. And despite skepticism about these new initiatives, I believe that they're the way forward. I recognise that it's early days for Vanguards, STPs, ACOs, LWABs, so we can't know how successful they will be. But the commitment to achieve lasting success is there from politicians, senior health leaders, medical, clinical and care professionals to design and deliver integrated models of care that meet people's physical health, mental health and social care needs. We know that multidisciplinary team working needs to be at the centre of this, and again, in this celebration of 50 years of the law school here at Keele, I would just point out how much multidisciplinary activity the law school has engaged in, far in advance of most law departments that I'm aware of in this country. We all want to see more services provided in the community and in people's own homes, rather than in hospital settings, with a larger primary care and community-focused workforce and a very much greater integration with social care, so that care is more joined up to meet those physical health, mental health and social care needs. But is this going to have sustainability? Well, integration is the new black, but will it be the fashion of the moment, or will it be something that endures? Well, it's at the heart of the 5-year forward vision, and it is where this government, including the current Prime Minister, the Chancellor, and the Secretary of State, want health and social care to be. Proof was in the spending review. The government was very clear that integration is not an if, but a how. And we've been given 3 how options: commissioner-led integration, provider-led integration, and integration through devolution. In the audience tonight, we have Andy Garner playing a major part in integration through devolution at the biggest of the 44 STPs, Devo Manc. But essentially this is saying you can do integration in the way that you choose. I'm optimistic about it because I need to be. We all need to be. Our current individual silo-based delivery system is proving entirely ineffective at meeting the rising demand, meeting the increased complexity of that demand, and in improving outcomes and well-being. So why pour more and more money into propping up an inefficient system when we need new models? Indeed, they're essential. This matters. This really matters. But what do we actually mean currently by integration and integrated care? Well, it's integrated care at the crossroads, defining the way forward. A paper by Stein and Ryder, International Journey of Integrated Care, about 8 years ago. Integrated care was expressed as encompassing diverse initiatives that seek to address fragmentation, but that differ in their underlying scope and values. But working across organisational boundaries to address fragmentation brings both complexity and ambiguity, and they can generate confusion and they can weaken accountability. The public needs assurances that public money is spent wisely when it is spent on partnerships rather than with individual organisations. And it requires belief that citizens' quality of life will improve as a result of that integrated working. And there is a lot of work still to be done in bringing that about. But despite the challenges, surely this has got to be a prize worth having. Building links between health and social care, the prerequisite to true seamless integration for those receiving care, has started addressing a number of potential obstacles, such as cultural and professional differences in thinking and approach across professions and sectors and organisations. The differing terms, the radically different terms and conditions in the workforces. Difficulty in gathering and sharing data and information. Achieving a balance between central, regional and local leadership, governance and accountability. And addressing the need to focus on the here and now as well as the future. Because if we're all being honest, focusing on the future is much easier than dealing with the present, especially when dealing with the present means maintaining high-quality patient care in an increasingly financially challenged environment. Now, I acknowledge the scale of these challenges, but it's by accepting them and coming together to deal with them via Vanguards, SDPs, LWABs and ACOs that progress will be made. But I have to ask, why has it taken us so long to arrive where we are, 11 years after Torbay, whilst internationally already there are many excellent models of integration with proven outcomes? And I want to share just 5 of those with you. Alaska Native people received their health care as beneficiaries of the Indian Health Service's Native Hospital, managed and centrally controlled from Washington, D.C., a mere 5,000 miles away. Patients waited weeks to get an appointment, or they went to the emergency service and were likely to see different providers each time. Mental and physical health were not connected. Patients and staff were dissatisfied. Local health outcomes were so poor that many people left the security of their native lands purely to seek better health care. Then in 1997, Alaska Native people were given control of their own services, and they set up a not-for-profit South Central Foundation, which took over all primary care and other services for the 60,000 people in Anchorage and the 60 rural villages through what is now called the NUCA system of care. Now, NUCA works through multidisciplinary teams providing integrated services in primary care and community settings, which include medical, dental, social care, and supported complementary and traditional healing methods, which were culturally highly significant. The aim was to improve outcomes and satisfaction without cost increases, and the results are impressive, and I'll share them with you. Improved access to primary care services, performance in the 75th centile of comparable measures. Patient satisfaction on the 90th centile. Reducing hospital activity included a 36% reduction in total hospital days, 42% reduction in urgent and emergency care use, and 58% reduction in visits to specialist clinics. These are huge figures. Now, whilst we're in North America, I must refer to Kaiser Permanente as an example of integration that has influenced and, in fact, given mentorship to Torbay amongst others. Kaiser has around 10 million members, 18,000 doctors, 50,000 nurses operating out of 650 medical centres and offices in the United States. Each of their 8 regional operations is itself an integrated system and works within a virtually integrated whole. It has high scores in patient satisfaction, in clinical quality metrics, with some of the lowest costs in the sector. 17 years ago in Quebec, Canada, PRISMA was a 4-year study to develop an integrated service network for older people with a single point of entry to multidisciplinary teams which assess, coordinate, monitor and evaluate as a single system. PRISMA did not involve either vertical or horizontal mergers or indeed the creation of new or greatly modified entities. And the results? Well, for no additional cost, the model produced significant reductions in functional decline amongst older people. It decreased their levels of unmet needs, it reduced emergency hospital visits and admissions, and not only did it do all of that, but it dramatically increased patient satisfaction. PRISMA is now the normal system of care for the elderly in Quebec. Well, leaving North America for Australia, where there's a massive difference in outcome for health between Aboriginal communities and the general population. Health One Mount Druitt is a virtual organisation that operates in a socially disadvantaged area of Western Sydney, based around a community health centre called the Hub. This model improves coordination of older people with complex health needs. General practice liaison nurses organise multidisciplinary case conferences. Note, it's, in this case, the GP liaison nurses who take the leadership in this. They coordinate the care between various care providers, and they ensure that the information about the patient is provided to the GP or the case manager. And an independent evaluation was completed in 2012, and the vast majority of providers and 100% of the GPs involved agreed that Health One Mount Druitt had resulted in improved communication and information exchanges between the patients and the providers, had improved the planning and care coordination that patients received. Patients admitted to the programme had fewer emergency department visits and shorter lengths of stay compared with the 12 months prior to the evaluations, and referrals to allied health services rose. But there were fewer referrals to the less specialised community home nursing. So people were getting much better quality care than before. Now, finally, I'd like to showcase an example from New Zealand. Back in 2007, the Canterbury District Health Board looked at the future and decided that if nothing changed, it would, by 2020, need a hospital twice the size of the already quite big hospital in Christchurch, which was the region's key medical facility, plus 20% more general practitioners, 40% more residential care beds. And this was unaffordable, and it was practically unachievable. So the Health Board set out to transform the way health and social care in the region worked and operate a one system, one budget, integrating care between the hospital, primary, community and social care sectors, with the aim that people would receive the right care at the right place at the right time from the right person. Now, the acid test. Despite Christchurch being hit by a devastating earthquake in February 2011, which tested the nation's entire healthcare provision, Canterbury rode it out and since then has continued to make progress. The sort of progress: fewer older people required hospital and residential care. 30,000 people received acute care in the community rather than in a hospital setting. And Canterbury's acute hospital admissions were 15,000 per annum less than the New Zealand average. Indeed, improved outcomes and cost control in Canterbury has been such that Dr. Jonathan Coleman, who's the New Zealand Minister of Health, instructed all New Zealand's district health boards to focus on integration and strong clinical leadership along the lines of Canterbury. So it was the change took place, it was carefully monitored, it was successful, and politicians gave it stickability across the system. Now, these 5 examples which I've chosen from a much greater number of integration methods and systems in a variety of countries with health and social care systems not unlike our own demonstrate that integrating health and social care services can deliver more effective, patient-focused care. And I've deliberately chosen examples based on Western liberal democracies, largely English-speaking nations, as particularly relevant for us and something that we can easily understand. But I would suggest to you that if they can do it in the USA, Australia, New Zealand and Canada, surely we can do it more broadly than just in Torbay. However, a word of caution. History is written by the winners, so there is an absence of evidence of where attempted integration has failed and an analysis of the reasons for failure. Health boarding. Although the narrative of integration will be focusing on the practicalities, that is, identifying the models of delivery, we must remember that fundamentally and absolutely unambiguously, integration is about the received experience of the patient, the user. So if we see integration as a narrative for person-centred coordinated care, it emphasises that service users and carers should be involved in the design and formal evaluation of the outcomes. So in our enthusiasm to promote integration, we mustn't allow narratives such as the operation was a success, unfortunately the patient died, to characterize measures of success, nor to seek patients' assessment of their medical care by administering satisfaction questionnaires in the post-operative recovery room when they are grateful just to be alive. So moving to the transformation of the workforce to meet the requirements of providing integrated services, the Care Act of 2014 provided a mandate for more formalised integrated ways of working between the health and social care sectors, and gave local councils a duty to promote integrated services. It established Health Education England to reform the education and training system for the workforce that, of course, integration demands, balancing national workforce priorities with the service needs of local healthcare providers and the quality and education requirements of specific professions. In so doing, HE, Health Education England, has a statutory role to pursue and enable the integration of healthcare services through the medium of workforce planning. Now, there's been much media coverage recently on unsafe patient discharges and a need for joining up discharge-related services and the subsequent care coordination. And Health Education is working on this with Skills for Care, of which I was the previous chairman. As a matter of priority, Health Education England is seeking consensus on where it might best invest funds for workforce transformation in order to deliver the new models of care, but in a way that will achieve the greatest patient benefit. And we need to do it at both scale and pace. Now, it's salutary to remember that it can take over a decade to train a medical consultant or a senior nurse. And many of those who got student places that we commissioned in 2015, some of them here at Keele, will still be working as healthcare professionals until 2070. So every time we make an investment in a clinical training place, we're making a hugely expensive set of assumptions about future healthcare needs and how best to meet them. So whilst the 5-year forward plan looks to what needs to be achieved by 2021, HE is taking a much longer view of the future demand to identify ways to support the development of a flexible workforce with greater skills in general healthcare that are transferable across all healthcare settings, because we can't know what the healthcare settings are going to be in the future. So we must develop a flexible workforce. And in developing a more integrated health and social care workforce, we're developing multidisciplinary teams in primary and community care. And again, you know, I take my hat off to the medical school at Keele for leading in this way. You know, their emphasis on community, your emphasis on community and primary care, the way you bring in other professions, you know, is a tremendous plus for the university in the way that we look at things in the whole healthcare system. At HE, we're developing new roles, and you will have heard of these probably, following 3 examples: physician associates, medical assistants, and nursing associates. And I just want to briefly mention what they are, since again, they sometimes appear to be shrouded in mystery. Well, physician associates, a physician associate is a healthcare professional who, whilst not a doctor, works to the medical model with the attitudes, skills, the knowledge base to deliver holistic care and treatment across both primary and secondary care, but under closely defined levels of medical supervision. Demand for physician associates is increasing rapidly. By 2020, we will have 30 physician associate training programs operational across the UK, with an annual output of around about 900 graduates, working in emergency medicine, general practice, adult mental adult medical specialities, paediatrics, surgical specialities, and so on and so forth. Medical assistance. Well, HEE published its response in October 2015 to the Primary Care Workforce Commission report entitled The Future of Primary Care, Creating Teams of Tomorrow, and is now moving forward to implement the recommendations. And those include developing a national role for medical assistants to support the work of clinicians in general practice as a way of relieving their administrative burden. And this role can also be considered, indeed we are considering it this way, as part of a talent pipeline for practice leadership roles such as practice locality, business and service managers. So this is a different way of looking at the capability we want to create in the new workforces. And the third one are the new nurse roles. And we announced in May last year the introduction of the nursing associate role. And this role will sit alongside existing nursing care support workers and fully qualified registered nurses. It has the potential to make a major impact on the nursing and care workforce, but it's not a panacea for the future workforce supply, nor a substitute for increasing the supply of graduate registered nurses. And just as fairly recently you saw the announcement of 25% more undergraduate medical places, then the main point of Jeremy Hunt's speech at the conference was 25% increase in nursing provision. And I think if you keep your eye on 25% for the future, it'll become a familiar theme. Now, nursing associates, they deliver hands-on care for patients, and they will help in the transformation of the nursing and care workforce. They will work alongside nursing care support workers, those are people with a care certificate, and alongside fully qualified registered nurses, bridging the gap between the two. It offers, very importantly, a new route for healthcare workers eager to progress in their careers to become registered nurses. Successful completion of the course can lead to a foundation degree in healthcare, and as a result of that, to go on to a shortened nursing degree. So, whilst we can design innovative new models of care, we must create a workforce with the right numbers, skills, values, and behaviours that can deliver them. And we need to support cultural change in clinical practice to allow for the more holistic, multidisciplinary working, which is not limited by organisational or professional boundaries and is genuinely patient-centric. The NHS, public health and social care system and the delivery of prevention, treatment and care will continue to change over the coming years. In the next 20 years, the percentage of people over 85 will double. And since, for example, in dementia, we know that over 85, we'll have 1 in 3 people with dementia. But more importantly, there will be so many more people with more than one health problem, multiple comorbidities, who will require a combination of health and social care services. And those comorbidities will become more complex, more difficult to handle. So an increased focus on managing complex comorbidities will place a much greater emphasis on the capability of the skilled generalist to manage, and an integrated health and social care service to deliver that. The boundaries between the NHS, public health and social care will become more blurred. Working in multidisciplinary teams, staff will need to be sufficiently skilled to enable them to work across the traditional sector boundaries, but not just with individuals, not just with patients, but with families of the people who have complex problems. And we need to break down barriers between primary and secondary care and other local public services, and be able to deliver preventative and other community health measures. So at HEE, we will need to train and develop a workforce that has skills that are transferable across these different care settings. If we're to follow the patient, we can't just have the skills in a series of different silos. They've got to be transferable. An integration of care will require more than 3 million staff employed by a range of different employers to work much more cooperatively and consistently as a single workforce, with a single focus on delivering the care that people and their carers want to receive. Yes, delivered in a coordinated way. But in the run-up to the last election, I can tell you there was talk of renaming Department of Health the Department of Health and Care. And maybe if integrated care does become a reality, then we may well see that name change. But again, I must draw us back from any delivery priorities in favour of recipient priorities, because integrated care must ensure that people have access to care and support that is focused around the outcomes that they want. And wished for outcomes are complex, because they involve decisions about self-management, supported management of conditions, and interventional choices. This will require professionals and organisations to work differently, joining up their care and better enabling people to tell their story just once, and to be supported to navigate the system, making the door that I knock on the right door. And the 6 workforce challenges that we need to consider in working towards integration is, can we recruit and retain the right number of people, the right attitudes, values, knowledge and skills who can work in integrated care? Can we create and maintain core attitudes, values and cultures right across the very separate and different organisational cultures that will be brought together? And can we plan the workforce effectively to support appropriate movement of staff whilst avoiding unacceptable vacancy rates where terms and conditions of employment vary very significantly amongst employers and indeed amongst sectors? And can we develop and maintain staff competence and performance when more than half the workforce is not regulated? How do we address the mismatch in the perceived profile and status of social care workforce compared to that of the health workforce? And how do we maintain a high-quality, coherent workforce that's employed across a wide range of employers who are operating in different markets? And finally, we should acknowledge that what works in one place may not work in another because of the variations in context and in relationships between stakeholders that I referred to early on in my talk. That understanding is widespread in social care, but it's less so in healthcare, where partly because it's much more extensively evidence-based, the general applicability is considered to be very much higher and contextual situational factors less important. I referred to Freeman Hospital, Derriford Hospital, renal interventions as an example of that. But what matters is that a particular model of integration does what it's supposed to do, which is to achieve the desired outcomes of patients, but it's done in a way that accords with its individual context. And this can sound common sense, but in fact it's a huge cultural challenge. The nature of surgical and medical interventions I've mentioned already. They are different and they're characterised very much in the case of social care by prevailing cultural factors. And that means that the entrenched NHS view of generalisability needs to be informed by the deeply insightful local authority perspective about the knowledge of their communities. Now, regardless of any changes in patterns of disease, the projected demographic changes in volume alone, overall population growth, number of elderly people, ageing workforce, increase in part-time workers in the NHS, raises significant challenges that we have to address. And whilst there is a strong focus on the need to increase the capacity and capability of the registered clinical workforces, According to the research from the former Centre of Workforce Intelligence, the major increase in workforce demand will be for the work of paid, unpaid and the voluntary workforce across the whole health, social care and public health system. So we have to make sure that we equip our workforce to be able to do that. And just to put that into perspective, currently the social care sector has got 17,000 employers. How many does the NHS have? A lot fewer than that. 94,000 regulated professionals, 1.55 million direct care workers, and hugely significantly, 5.5 million unpaid family carers. So we see millions of staff and carers with different structures, work practices, employers, skills and experience, which we have to bring together and devise how they're going to work together. Structures are important, relationships are important. As I said before, leadership and resolve need to be shown. But at its core, we have to recognise that successful integration necessitates the successful resolution of these workforce issues. So how does our journey compare, if at all, with that of Lewis Carroll's crew in pursuit of the Snark? Well, both have a clear objective, but neither knows beforehand how the objective will be met. We have a strategy of a plethora of approaches, any of which, or none, may succeed. Lewis Carroll's captain had a strategy, and that was his map to reach his goal. But you remember that the map was blank, and so his approach was simply to sail for a period of time, and then the crew of 10, accompanied by the Greek goddess of hope, landed at a randomly chosen spot. They landed where the boat beached. Now, hope inspired the crew, who paired off as partners to hunt the Snark. Just as successful examples of integration are based on particular partnerships amongst the workforces. But when the baker finally found the Snark, both he and the Snark softly and suddenly vanished away. But whereas, like Lewis Carroll's baker, I believe that our hunt will reach its objective. But for us, that future will not softly and suddenly vanish away. For our Snark is the future you see. Thank you.